Good morning, everybody. Thank you so much for joining us this morning. My name is Dane Binder. I'm the Chief Operating Officer here at Sierra Tucson. I want to first start out by saying thank you to all of our vets and a happy Vets Day. Thank you to all of our active military as well. We really appreciate all your sacrifices. So from everyone here at Sierra Tucson, heartfelt thank you. So thank you all for joining us this morning. I'm excited to chat with you a little bit about harm reduction strategies for substance use. Next month, I believe we're going to be doing another Nourishment webinar on harm reduction strategies for suicide prevention and self-harm. So if today's topic is of interest to you, I encourage you to attend not just a month from now, but all of our Nourishment series webinars. So thanks so much for sharing your morning with me. So we're going to go ahead and get started. Again, this is a topic that's pretty near and dear to my heart. I have a history of working with folks in the substance use field and behavioral health field for about 10 years now. As everyone is very aware, there's been a pretty substantial increase in overdose deaths that's been plaguing our country for quite some time now, for the last couple of decades. So, we'll talk a little bit about a few things here, but this harm reduction in general was born out of a desire to reduce those deaths. So harm reduction, as you might guess from that moniker, is about reducing harm for folks who have been using different substances, and the idea is that we want to, if people are going to use, which we know that they are, we want them to use in a way that's safe. And that prevents fatal encounters in particular. So this presentation is really for anyone struggling with substance use, as well as, next month is going to be about depression and suicidal ideation, but this particular presentation is about substance use in general. And then additionally, it's for folks who have family members or friends of anyone struggling with substance use, and then healthcare providers in any field of any kind, because honestly, it spans the entire healthcare continuum. So again, what we're going to do is we're going to define harm reduction. We're going to look at the rates of fatal overdose, and then lastly, we'll discuss overdose prevention strategies. So the harm reduction is a loosely defined term. It's not something terribly specific that everyone agrees upon. So there's not one definition. But like I said, generally what we want to do is we want to recognize that people are using substances out there in the world. It's a fact, and we can't ignore it. And but what we can do is, and relapse as well is a big part of the recovery process and the recovery journey. What we want to do is we want to recognize that that is a reality, and we want to teach people who are using and teach family members how to keep everyone, and friends of course, how to keep everyone safe when they're using, which again is just the reality in this world. So in essence, harm reduction strategists recognize that substance use and relapse happen. So when people are not able to stay sober forever, they should implement these practices that minimize the likelihood of fatality. And again, next month we'll talk a little bit about self-harm and suicide harm reduction strategies. But generally, just to give you a little idea of what we'll discuss when that comes up is we talk in particular about reduced access to means of suicide, which is a really important component of suicide prevention and any safety planning that happens with folks who are faced with self-harm thoughts and suicidal ideation. But again, harm reduction, per harmreduction.org, does not attempt to minimize or ignore the real and tragic harm that's associated with substance use. But we also, as harm reductionists, we choose to recognize that this is a reality, and again, work on strategies that folks can implement to reduce the harmful effects of substance use rather than to ignore it. So when, as behavioral health professionals, when we talk about relapse, we talk about the stages of change. So generally, what happens is you have folks who start out here under the pre-contemplation stage of change, and that's generally going to be your folks who are using, who may not necessarily recognize that it's an issue, or they may not be ready to face their recovery journey. But eventually what happens is hopefully they start to move into that contemplation stage. And once in contemplation, then they realize, okay, maybe something is going on that I really need to look at this. My life is not as great as it could be. It's affecting my health. It's affecting my relationships. It's affecting, any sorts of social interaction that I have with folks. and it's just affecting my life adversely. So then they start to go into the determination stage, which looks a little bit like, okay, I'm going to face this. I'm going to do it. I'm going to start making some phone calls to Sierra Tucson. I'm going to start talking to my family about making these changes. And then they move on to the action stage. So then they are full on engaged in treatment. They're doing well. They're looking at graduation. And after that, they move on to the maintenance stage of sobriety. So at maintenance, then we're looking at folks who are attending, potentially attending group meetings with 12-step or with Smart Recovery or what have you. They may be seeing a counselor every so often, but they've got some sobriety under their belt, and they're just trying to maintain that sobriety. And then what can happen is one of two things. We hope for a permanent exit, which a lot of times does not happen. So if they don't permanently exit this stages of change, what happens is they relapse. And so then after they relapse, then it goes back through the stages of change from contemplation, determination, and action and maintenance. So when you look at this chart over here, it gives you a little bit of an idea of what relapse rates for substance use disorders look like as compared to other chronic health conditions. So hypertension, for example, what that might look like for folks is you've got a treatment plan that has some hypertension medication, so should be taking those meds. You should be changing your diet. You should be exercising. And all of those things are part of your treatment plan with your doctor. And so, in the action stage, in the maintenance stage, what that might look like is you have fully engaged in your treatment plan. You're seeing a personal trainer. You've lost some weight. You're managing your hypertension. You're taking your medication. And then you fall off the wagon and you start to eat unhealthy again. You stop working out. And so that's what relapse might look like for hypertension. So really you can see how in substance use, it's really not that different in the general sense that, you've got pretty common variables among those two things. So the stages of change doesn't just pertain to substance use disorders, but also pertains to other chronic health conditions. I want to take a minute to discuss in particular opioids, because this presentation is not just specifically about opioids. It's about substance use in general and harm reduction strategies in general. But a lot of this there's a lot of momentum these days to curb opioid overdose deaths. And the reason for that is we have had almost 500,000 people die since the 1990s. And what I put over on the right side of the screen here is something that I pulled from the CDC website, and it essentially just kind of gives you an idea of where this was bred out of. So in the 90s, we saw a huge increase in the number of prescription opioid overdose deaths. And those were largely in part due to primary care physicians and other doctors who were, essentially told by the pharmaceutical community that, these opioids were, have a place in medicine, which is a very valid point. I'm not here to say that it doesn't. But what the providers really were not fully informed on was exactly how addictive these medications were. So what happens is people would start out getting prescribed these opioids. They would have some trouble, essentially getting off of those opioids. So what we've got is overdose deaths really started to rise back in the 90s. And then people were becoming addicted to these prescription opioids. And then from there, what happened was the provider community, and the government essentially said, hey, we've got to pull back on some of these prescriptions because there's too many opioids out in the community. So what happened was they became a lot more difficult to get. So people went to more unsafe methods of obtaining opioids because they were physically dependent on them. They were addicted to them. So they would turn to the streets to find heroin. Heroin, being an illegal opioid, has a much higher potential for overdose. I shouldn't say that it's much higher potential for overdose. What I should say is the means of methods of use with heroin lends itself to fatal overdoses in a pretty high number. People are using it in an unsafe way, particularly with intravenous drug use, so shooting up and injecting, what have you. So that became a really big issue for us back in around 2010. And then in 2013, what happened was we saw a synthetic opioid spike in overdose deaths. So the synthetic opioids were coming in from other countries, and were flooding our streets. And fentanyl became kind of the big issue. Carfentanil, those types of things that were being manufactured illegally and brought into the country. So we really struggled with. We still continue to struggle with synthetic opioid overdose deaths. I want to stop here real quick because this is a really important piece to discuss. So Narcan is something that you may have heard of. It's called Narcan, naloxone. A lot of times first responders will carry it. And so you may have heard of it. But Narcan is actually a really effective way at reversing the life-threatening effects of an opioid overdose. So what happens is someone uses a bunch of opioids, going back a slide, if they have used, whether it's heroin, synthetic opioids, prescription opioids, or whatever, if they have overdosed, if someone is there to save them, they can actually take this Narcan nasal spray, stick it in their nose, push the plunger up, and the spray comes out of the tip here and into the nasal cavity. And what happens then is it essentially forces the opioids off the opioid receptors and reverses the effect of the overdose. So the nervous system starts responding again. And so it's become a very effective tool for folks in the street in particular and in homes where opioid use is common. So I personally have had a number of folks who have reported I used to be involved in a program where we would distribute Narcan and naloxone kits into the community. People would come back to me and say, hey, I saved a life. Someone I didn't even know. I saw them a bunch of people surrounded them, on the street under a bridge or whatever, and I pulled out my Narcan kit and I was able to bring them back to life. So it's a really effective tool for folks who encounter individuals who are using opiates, or for family members who have someone in their home who uses opiates. Additionally, it's good for healthcare providers to discuss Narcan with their patients, in particular those who are on medication-assisted treatment or are prescribed opiates. So it's something very important for people to discuss with their physicians or with any sort of harm reduction community partners that you might have. So I want to talk for a minute about some of the statistics with respect to not just opiates, but with substances in general. What we're really starting to see is not just a climb in synthetic narcotic overdoses, but also with cocaine and psychostimulants. And so what's alarming about that is that now we're not just looking at heroin and opiates as a leading cause of overdose death. We've also got these other drugs that are different in nature than opiates. So we're starting to see not just a opiate crisis, but really a substance use crisis. And what this chart does not include is also the increased rate of alcohol use. In particular, since COVID hit, we have seen a substantial increase in alcohol use. So really across the country, we're starting to see a very substantial uptick in substance use in general. And so, cocaine and psychostimulants, which methamphetamine is one, we have to be very careful about anyone who is working on their recovery, making sure that they understand that it's not just opiates that are dangerous. It's also methamphetamine and cocaine that can lead to death. So we have to be very careful as healthcare providers, as family and friends of those who are using those substances, to discuss the harmful effects of those drugs. Fatal overdoses, especially after a period of sustained abstinence, are far too common. And you're going to hear me talk about that more in depth. But if there's one thing in particular that I really want people to take out of this presentation, it's that fatal overdoses after a period of sustained abstinence are a particularly high risk factor, or are particularly common. So the particularly high risk factor is use after a period of sustained abstinence. And that can even be just a couple of days. And we'll discuss why that is. So we'll talk about some harm reduction strategies so that we can essentially lay a foundation for how we can prevent those fatal overdoses. So again, I want to reiterate that relapse is a reality of recovery. It's something that just happens. It's a fact, and we don't want it to happen, especially those of us who work in the substance use treatment field. But we need to prepare our clients, or if you are going in through recovery yourself, you need to prepare yourself that it may happen. If it doesn't happen to you, it may happen to someone that you know. And so we need to make sure that we're doing it in a safe way that's not going to be fatal. So it's very important that harm reduction strategies are discussed. But again, I want to point out that this does not encourage people to use. So anytime I have this discussion with a client, I let them know that, hey, we do not want you to use, okay? That's not what this discussion is about. We want you to stay sober. We want you to stay focused on your treatment, and we have, a treatment plan for how you can do that. And in the event that it does happen, these are the things you need to keep in mind to make sure that you do not die when you relapse. So on the left side of this page, we've got 5 risk factors that we want to discuss with everyone. So restricting accessibility when using or using alone. So that is essentially using behind a closed locked door and not telling anyone about it. Combining drugs is the second risk factor. Fentanyl and adulterants, so essentially mixing fentanyl into methamphetamines and cocaine in particular. And pre-existing respiratory illnesses, and number 5, the big one, tolerance changes. So countermeasures for restricting accessibility when using or using alone is always tell an in-home friend or family member before using, and do not use behind a locked door. A countermeasure for combining drugs is not combining different types of drugs, very, very important. And for 3, the fentanyl adulterants, we want to test our supply as often as possible. That may not be accessible for everyone, but it's what we want to try. For pre-existing respiratory illnesses, anyone with pre-existing respiratory conditions should avoid central nervous system depressants, and we'll talk about what that looks like. And then for tolerance changes, we want to start off with a very low dose after a period of abstinence if you are going to relapse. So we're going to break down these 5 risk factors one at a time. So the first one is using alone. So when people are using alone or behind a locked door, or they're not telling their family or friends that they are using, if someone experiences an overdose and they have restricted access to their person, it's essentially impossible to help them. So we want to encourage folks to be open and honest about their use. That's why we don't want family members to discourage conversation. If someone is using again, we need to be open to that because we don't want them to be using alone in an unsafe way. We don't want to encourage them to use, but we want to be made aware of it as family members and friends. So when folks are using substances, an important countermeasure, like I said, is alerting them to the use, never locking the door to keep people out, and maybe using with a sober friend in the room is a really good way to prevent an adverse outcome. And this also pertains to alcohol use. So alcohol intoxication leads to diminished impulse control and poor judgment. So when people drink alone, they may be more prone to, or someone may not be able to stop them from driving while under the influence. So nobody is there to take your keys. Passing out or falling down and injuring yourself, and increased risk of attempting suicide. So when folks are suicidal and drinking, it, like I said, reduces impulse control and has an adverse effect on judgment. So people who are prone to suicide may be more likely to attempt suicide. When other people are there, they're there to intervene. So it's very important, again, that people are not using when they're alone, if they're using to excess in particular. Okay, so moving on to the second risk factor, combining drug types. So there's a couple different drug types that I want to discuss. We have opioids, we have stimulants, we have depressants, and alcohol. So when it comes to opioids, a couple of examples are heroin, fentanyl, oxycodone or oxycontin, hydrocodone or Vicodin, morphine. There's several others. So opioids, in essence, block pain sensations, which is why opioids are often prescribed for pain purposes. But the effects of opioids are that it induces drowsiness, reduces your body temperature, and slows your heart rate, your blood pressure, and your respiration functions. So the respiratory functions in particular are of concern because what happens is when you use too much, it decreases your respiratory functions too much. And that's why you see when people overdose, they end up with purple fingertips, they end up with purple lips, they end up with dilated pupils and slower heart rate, shallow breathing, or not breathing at all. They're difficult to wake up. That is generally what happens when you have overdosed on opioids. And so if you do encounter someone in that instance, if you have a Narcan kit, that's the time when you want to pull the Narcan kit out, administer the Narcan, call 911 first so that paramedics can get over there quickly. But having Narcan available is particularly important in those instances. Stimulants are methamphetamine, shorthand term is meth. Some street terms are crystal, glass, those types of things. You have Adderall, which is a prescription stimulant. Cocaine is a stimulant, and Ritalin is a prescription stimulant. And opioids, it actually has the opposite effect that opioids do. So stimulants speed up your central nervous system, right? So it's an increased heart rate, increased body temperature, blood pressure. It also increases energy, focus, and attention, which is why it's prescribed. So when it's used in an appropriate way, that's why Adderall and Ritalin and those types of amphetamines have a place in medicine. It increases alertness. But when it's abused, when too much is used, your body can work a little bit too hard, and so it's particularly important not to use too much of any drug, but stimulants in general. There are other types of drug depressants. So some things that you may have heard of are benzos or benzodiazepines, date rape, barbiturates. Those are a different kind of depressant. So similar to opioids, they induce drowsiness, they reduce body temperature and slow your heart rate, may reduce blood pressure and respiratory functions. So, and then you've got alcohol, which is also another type of depressant. So that can actually affect several parts of the brain, but in general, it contracts brain tissues, destroys brain cells, as well as depresses the central nervous system. So what happens when multiple depressants are mixed? So essentially what happens is using multiple depressants at once, in particular opiates and benzos, they have a significantly increased likelihood of resulting in overdose. And that's because they're both depressing your central nervous system. So like I had mentioned, signs of overdose include, but are not limited to, loss of consciousness, lack of response to stimuli, shallow breathing or no breathing at all, purple lips, fingertips, pinpoint pupils, difficult to arouse, not responding to a shake. And what we do a lot of times is, if we believe in the behavioral health community, if we've encountered someone who's overdosed, we'll take our knuckle from our middle finger and we'll rub it on their sternum as hard as we can. And if you want to do that to yourself right now, you can tell it's very uncomfortable. So if someone is just asleep, they're going to wake up. But if someone has overdosed, they're not going to respond to that. So it's a very uncomfortable sensation, and that's how generally one of the tools that we use to determine if someone has potentially overdosed. The other signs of overdose are environmental. So you can look on the ground, find a pill bottle that was a prescription opioid pill, and you can see that it's empty, or if there's a tourniquet and syringe, a spoon, and a lighter, those types of things. So when you've encountered someone that you believe is overdosed, there may be some environmental signs that you can observe as well. And what happens when you're mixing depressants and stimulants is you're essentially making the body work extremely hard because you have two stimulants that are doing you have two substances that are doing two different things. You have opiates, for example, that are reducing your central nervous system. You have cocaine, as an example, that is increasing your body's response, and it makes the body work very, very hard. So it also, in particular, alcohol and cocaine can make a chemical in the body that's toxic to the heart and can be fatal. So when mixing two different types of substances, not just two depressants, but a stimulant and a depressant, it can make the effect on the body fatal. So it's important to discuss that with our family, friends, or any patients that we're working with. So countermeasures to mixing drugs, really this one is just education. So we need to educate our friends, family, or our patients to use only one drug at a time, and this includes alcohol. We need to make sure that they're using small amounts of substances and taking it slow, and being aware of tolerance changes and never using alone or behind locked doors. So again, we want to make sure that people are abiding by those safety protocol. So The third risk factor are street drugs that are cut with adulterants. So the Drug Enforcement Agency in 2018, the National Drug Assessment that they put out, documented the extent that fentanyl is mixed into heroin or counterfeit opioid prescription pills. So when fentanyl is mixed into heroin, and a person goes out to buy some heroin off the street, they expect the heroin to be at a particular strength. When fentanyl is indoctrinated into the heroin, when it's included in the heroin, it actually leads to a much higher high and a much higher likelihood of overdose. The same thing is true of counterfeit opioid prescription pills that are found on the streets. So what happens is the cartels are manufacturing these drugs, and they're including fentanyl in there when it wasn't included before. They're also including it in meth and cocaine, and that is a huge issue because someone may have never used an opioid in their life. And if they go and use what they believe is their traditional amount of meth or their traditional amount of cocaine, and it's been cut with fentanyl, they've been introduced unknowingly to an opioid that has a huge overdose potential. So that's why one of the big reasons why we're seeing a huge spike in methamphetamine and cocaine deaths is because fentanyl is cut into them without them knowing it. So they may not even know that it's happened. So here are a couple of charts and examples of fentanyl combination reports, so that you can see that it's really started to gain traction, and we hear a lot about West Virginia as ground zero for the opioid epidemic, and that's reflected in the right part of that chart at the top there, where you can see that semi-synthetic prescription pain medications have really contributed to the death toll there. It's really been a problem. So in Ohio as well, Ohio is of particular concern, as well as everywhere else in the nation, but those two are some of the leaders in the clubhouse, so to speak. So when it comes to mitigation strategies, what we want to do is we want to have fentanyl test strips available. Now, this is not a foolproof method, and I'll explain why. But it's important that when you have someone who is using opioids, a good harm reduction strategy is to get them fentanyl test strips. And again, for people who are using meth, people who are using cocaine, getting them some fentanyl test strips is important because they can test a little bit of their supply to see if it's laced with fentanyl. So to the right, you can see what a fentanyl test strip looks like. If there's two lines, there's no fentanyl. If there's just one line, there is fentanyl in it. So we want to make sure that we are getting these to our clients, our family and friends as much as possible. And you can see on the left there what it looks like when a test strip is used. But again, other mitigation strategies, we want to make sure people are not using behind locked doors. Someone knows when they're using, and they've got a Narcan kit available, even for folks who use methamphetamines and cocaine. So this chart, this graphic in particular, I like because I think it kind of gives a visual. I'm a very visual person, so it gives you a visual explanation as to what it looks like when fentanyl is introduced into a tablet or into a drug. So the green dots are the tablet. Just consider that to be a tablet matrix. We'll call the purple or the maroon dots fentanyl, and when they're blended and formed into tablets, you can see at the bottom there how fentanyl can kind of trickle into one side or the other, or maybe the whole pill. The folks in the cartels who are manufacturing these drugs don't particularly care what if the tablet is evenly distributed with fentanyl. So sometimes you get this middle pill where fentanyl is heavier on the right side than the left side. And so you may test, or on the second to the left, you've got one side that has fentanyl in it and one that doesn't. So even if you do use a fentanyl test strip, you may not pick up on it. So it's not a foolproof method, but it should still be practiced as a harm reduction measure. We're running out of time here, so I'm going to go through these last two a little bit more quickly. But for pre-existing respiratory illnesses, just the bottom line is if you've got a pre-existing respiratory illness, you need to make sure that you are very careful when you're using. So COPD, asthma, people who have smoked their entire lives, people who have lung disease, pulmonary hypertension. Be very careful when using any sort of depressant because the depressant is going to make breathing more difficult. So if you're doing that, it's important that you use in a very, very, very small amount, in a very safe manner. And then tolerance changes. This is the big one that I really want to bring home to everybody. If people use more as time goes on, they start to build up a tolerance. It's true of alcohol. It's true of other drugs. When you stop using, even for a small period of time, your tolerance goes down. And if you go back to using the same amount at the height of your use, you are very likely to experience an overdose. So it's very, very important that anyone who goes to jail, anyone that goes into the hospital, anyone that goes into drug treatment, that it's very, very important that you talk to them about tolerance change, because if they go back to using that same amount, it's very likely that they are going to overdose. This is very near and dear to my heart. I had a family member pass away recently as a result of this. He went to the hospital for 7 days. He went back, used the same amount of opiates that he was using before he went in, and he passed away. And I know of several other folks who have had near fatal encounters after leaving some of our programs. So it's very important that you talk to folks about this and spread the word that tolerance change is one of the big risk factors of overdose. So make sure that you take that home. So even if a few days of decreased use can lower tolerance. So make sure that people are taking it slow when they leave your facilities, when they leave your care, and make sure that you're talking to family and friends who have a period of sustained sobriety, letting them know, hey, I heard this awesome presentation by this really awesome COO at Sierra Tucson. Make sure that if you do relapse, that you do it in a safe way, use a small amount, take it slow. All right, so I'm going to open it up to questions here. All right, so one of the questions I have here is how can I get a naloxone or Narcan kit? Really good question. So what you want to do is you can work with your primary care physician, let them know that, hey, I have someone that I know in my family who has an opiate use disorder, they have a drug use disorder. I'd like to have naloxone available in the event that they overdose on accident. Your PCP will generally prescribe you one. In some states, it's available over the counter, so you can go into Walgreens, CVS, what have you, and get a naloxone kit there. Or you can work with a community partner who distributes Narcan or naloxone kits. Sometimes it comes in a vial with a syringe as opposed to a nasal spray. And don't let that intimidate you. All you have to do is put the needle into the vial, pull the medicine in, stick the needle into a large muscle like a quad, buttocks, shoulder, and insert the medicine. You can do multiple doses. That's not going to hurt anybody, and it won't have an effect on someone who hasn't overdosed on opioids. So keep that in mind too. Always important to call 911 first. The second question, what role does medication-assisted treatment play for alcohol or substance use disorders? Really good question as well. So alcohol and opiates in particular, a good way to get folks the help that they need and prevent overdose, get them started on Suboxone, methadone, Subutex, Sublocade, Vivitrol. Vivitrol in particular for alcohol cravings is a very effective way at reducing cravings. So talk to your doctor about those medicines. Talk to them about medication-assisted treatment for alcohol or opiate use disorders. And it looks like that is it. So thank you all for attending. Really appreciate you. If you have any questions, my email address is attached in the handout, and we really appreciate you coming by and sharing the morning with us. Again, thank you to all of our vets.